pretty quickly. There's a lot of material to cover. So we'll move quickly. Ideally, I like to be interactive and ask people to interpret EKGs as they fly up there and go around the room. And obviously, we're not going to be able to do that. So if you want to help me, just feel free to come off mute. If I ask a question, answer it so that everyone can hear, and we'll be able to move quickly. Otherwise, it'll be a little more awkward. So that's my request to you all. And I'll try to move quickly and make this useful for you. Not spend too much time on things that are too much review, but hopefully maybe shore you up on some things that you already know, and maybe give you a different way to think about certain things that you might have a little struggle with. So today we're going to review normal rhythm generation. How does a normal heart rhythm get generated in the heart? We'll talk about normal conduction and how that rhythm then spreads through the heart. We'll talk about then some abnormal rhythms. And then abnormal conduction, and then if we have some time at the end, we'll do some STEMIs and figure out why a STEMI looks like a STEMI, and what are the things that aren't STEMIs can mimic STEMIs. So that's the roadmap we'll follow tonight. So when we talk about rhythm generation, we're talking about what part of the heart is setting the rhythm for the heart, or which part of the heart is acting as its pacemaker. And so in a normal heart, the rhythm originates in what we call the sinoatrial node, or the SA node. And this is pictured here over on the right-hand side. The SA node is in the right atrium. And it's an area of the heart that generates rhythms. That electrical impulse then travels through the atrium. It crosses over to the left side and gets the left atrium. And then it goes to the atrioventricular node. Or what we call the AV node, which is situated, as it sounds, right at the junction between the atrium and the ventricle. And it's right in the middle of the heart and the septum. Now, in the AV node, there's a normal delay. One of the jobs of the AV node is to take this impulse, put a little pause on it, and allow a little gap between atrial contraction and ventricular contraction. If your atria and your ventricles contracted at the same time, your heart would not be efficient. Your valves wouldn't know whether to be open or closed. And so there needs to be a delay between the atria contracting and the ventricle contracting. And that delay happens in the AV node. And then the impulse from the AV node travels through this bundle of His, which is a single fiber. That bundle then splits into two branches. And very creatively called the right bundle branch and the left bundle branch. And then from the bundle branches, the impulse goes to the ventricles through the muscles, and that happens a little bit more slowly. And so this process happens with every single heartbeat, and every part of this process is reflected on the EKG. So we don't really see the sinoatrial node firing on the EKG, but when you see the atrium depolarizing, that gives us our P wave. We then get this pause between the P wave and the QRS. That's the pause in the AV node that we were talking about. And then the conduction goes down through these bundles, and the ventricles depolarize, and we see the QRS complex, which is ventricular depolarization. And then when the ventricles repolarize, we get the T wave. So this is a depolarization wave of the atrium. This is a depolarization wave of the ventricle. This is a repolarization wave of the ventricle. You may ask, well, why don't we see a repolarization wave of the atrium? Why is there nothing to show us when the atrium is repolarizing? Two reasons for that. One is that the atrium is much smaller than the ventricle, and it's not that big of a wave. And then the second reason is that it would happen right in here, and it's usually obscured by the QRS complex. So we don't see an atrial repolarization wave, but we see the other three. Questions so far? All right, so like we said, the P wave is atrial depolarization. That pause between the P wave and the QRS is what's happening in the AV node. The QRS complex is ventricular depolarization, and the T wave is ventricular repolarization. Not that you need to know all that in detail, but it just helps understand what we're looking at. So the sinoatrial node, the SA node that we talked about, has a normal rate at which it sets off an impulse, and that rate in an adult who's healthy is usually somewhere between 60 and 100 beats a minute. Now, what you may not know is that the AV node has a rate of its own, and that's usually somewhere between 40 and 60 beats a minute. And then the ventricle actually has a rate of its own, and that's somewhere between 20 and 40 beats a minute. So why that's important is because whatever's working the fastest is going to be the one that sets the pace for the heart. So usually it's the SA node. And because it's going fastest, that's the one that sets the pacemaker of the heart. And so our heart rate is usually between 60 and 100 beats a minute. If there's some disease in the SA node where it stops doing its thing, well, what's going to happen? You'll have nothing here, and the AV node will kick in because it's the next fastest thing, and it goes at 40 to 60 beats a minute. If there's some problem with the AV node and the SA node, then the ventricle will kick in, and it's at a rate of 20 to 40 beats a minute because it happens to be the fastest pacemaker. So if someone's sinus rate slows below 60, sometimes their AV node will pick up and we'll get a different rhythm. So we'll talk about that. So how do we name rhythms? How do rhythms get their names? And this may be a little bit, again, review, but I'm surprised how many people don't think through this. And so I figured I'd put it in here. We name the source of the rhythm. What part of the heart does it come from? And then we name how fast it is. So is it tachycardic, normal, or bradycardic? So that seems awfully simple, but here we go. What are our possible sources where the rhythm can come from? They can come from the SA node. If a rhythm comes from the SA node, what do we call it? Anyone?
Sinus.
Sinus rhythm, right? The S and SA is sinus, sinoatrial node, so we call that a sinus rhythm. It could come from somewhere else in the atrium, but not the sinus node. What do we call that?
No, I'm just.
Oh, I thought you were going.
Sometimes we call that just an atrial rhythm. Sometimes we call it, because it's above the ventricle, we'll call it a supraventricular rhythm. But you could have the normal beat starts in the SA node. You could have a rhythm start somewhere else in the atrium. We already talked about that, the fact that the AV node has its own automaticity and will start some rhythms. So we call that, because that is at the atrioventricular junction, we call that a junctional rhythm, right? Or the rhythm can come from the ventricle. And so we call that a ventricular rhythm. So these are essentially the four places where a rhythm can come from in the heart. And if you think about it, every rhythm that we know about has a name that corresponds to one of these sources of the rhythm in the heart. And then the rate in adults is going to be, if it's less than 60, we're calling it bradycardia, right? 60 to 100 is normal, and greater than 100 is tachycardia. With that combination, you can name just about every rhythm there is. Where did it come from, and how fast or slow it is. So let's do it. What do we have here?
Sinus.
Not just sinus.
Almost sinus.
Normal sinus, right? And when we say normal sinus, that means it's between a rate of 60 and 100. So this is normal sinus rhythm. And it's got its name normal because it's between 60 and 100, sinus because it's coming from the SA node. What do we got here?
Sinus.
Sinus tachycardia, right? It's sinus because it's coming from the SA node, tachycardia because it's greater than 100 beats a minute, sinus tachycardia. And what do we have here?
Sinus brady.
Sinus bradycardia, right? It's sinus because we got a P wave, it's coming from the SA node, and it's bradycardic. That's why it gets the name sinus bradycardia. This is not that hard. What do we have here?
SVT.
And what does SVT stand for?
Supraventricular tachycardia.
Yeah, so it's coming from somewhere above the ventricle. We don't know exactly where, so we just make it a wastebasket term of supraventricular, and it's fast. And so it's tachycardia. So that's why we call this supraventricular tachycardia. Some people call this atrial tachycardia because it's coming from above the ventricle. How do we know this is coming from above the ventricle?
The width of the QRS complex.
Because the QRS complex is what?
Narrow.
Is narrow, right? And we'll get to this a little bit later on, but ventricular rhythms are wide, complex, and anything above the ventricle is narrow. So this is supraventricular tachycardia. What do we have here?
Functional.
So this is junctional, right? And it's junctional because we don't have P waves before it. So it's not coming from the SA node, it's not sinus. Why is it not ventricular?
Because the complex is narrow again.
Again, because it's narrow, right? So this is a junctional rhythm. Do we call this junctional bradycardia? Junctional, what do we call it?
Functional rhythm.
Functional rhythm.
It's just junctional rhythm. We said that the AV nodal junction goes between 40 and 60 beats a minute, right? So this is 300, 150, 175, 60, 50, 40. This is between 40 and 60 beats a minute. This is just a junctional rhythm. We don't call it normal junctional rhythm because it's not normal, but this is what a junctional rhythm should be. It should be between 40 and 60. If this is what you're seeing, it's a junctional rhythm. What do we call this?
Ugly.
Sorry about the blue color there, a little hard to see.
Yeah, it is.
It's still a junctional rhythm, isn't it? With
It's still a junctional rhythm, but why is it, how is it different from the one
That's that
before?
inverted
It's
T
a
wave.
functional tap.
Two differences. Somebody said the one of them, and I think you said there's retrograde P wave. See this thing here? That's a P wave that's being sent up from the AV node rather than coming down. Rather than coming down from the SA node. If the rhythm is starting in the AV node, it's junctional. Then it travels up, and you get a P wave that comes in the middle of the T wave here because it's going retrograde. So that's one difference. What's the other difference?
It's faster.
Great.
Okay.
The rate. Is this a rate between 40 and 60?
No.
No. So this is fast.
Functional tachycardia.
So you call it junctional tachycardia. What else could you call it?
Mhm.
'Cause it's not technically tachycardic. It's not greater than 100.
Just accelerated.
Yeah, so we call this accelerated junctional
Thank
rhythm,
you.
right? This is an accelerated junctional rhythm. So it's junctional, but it's faster than the junctional rhythm should be. So we give this one a special name, accelerated junctional rhythm. And this one happens to have the retrograde P waves as well. Any
Chair, can I
questions
ask
on
you a
that?
question?
Yeah.
So you're saying it as retrograde P waves, but doesn't that take away from the definition of it being junctional?
It doesn't. It's just something that happens because the P wave is not before the QRS. This is not a P wave that is being conducted and causing the QRS. This is just, I don't know if you guys have me on camera, but you have the AV node and the impulse at the same time is going up and down from the AV node. So it's depolarizing the ventricle, going down the heart, and then because it's going retrograde up the heart, it's depolarizing the atria, but that's not really an effective depolarization. So typically the atrium, because it's coming from the SA node, is going to depolarize first, and that's going to go to the ventricle, and that would make it not junctional. But this is retrograde. It's not normally conducted. I don't know if that helps.
Yes, thank you.
All right. What do we have here?
Ugly.
Ugly.
Very ugly.
Something junctional. I mean, ventricular.
Ventricular. Why is it ventricular?
It's wide complex.
It's wide complex. What's the rate?
So it's probably
Slow.
about 3.
It's gonna be less than 40, right?
Mhm.
So this is when the SA node and the AV node aren't doing anything, and the ventricle just starts picking up its normal rate, less than 40.
Ventricular.
And so this is just called a ventricular rhythm. Sometimes we call it idioventricular rhythm. It gets that little nickname too. Sometimes it gets called an escape rhythm. And the reason we call it an escape rhythm is because nothing else is going on. So this is the last thing left. And so this is a wide complex. It's ventricular. When electrical impulses go down the wires, so to speak, they're conducted quickly. When electrical impulses have to spread muscle cell to muscle cell, they go slowly. And so that slowness of the conduction through the muscle cells makes the QRS wider. Whereas if it's going down the conduction system, it goes faster and it makes the QRS narrower. All right. So this is a ventricular rhythm. What do we have here?
P-tach.
It's another
Monomorphic.
ventricular rhythm. But is it going at the rate that a ventricular rhythm should go?
It's P-tach.
No, right? This is ventricular tachycardia. That's why it gets its name. The rhythm's coming from the ventricle and it's too fast. So here's some things that don't quite follow the naming. What do we have here?
AFib.
This is atrial fibrillation. So here we're just talking about what the atria are doing. We're not actually talking about what the ventricle is doing. And if we wanted to be technical, we would say that calling it atrial fibrillation is not enough. If you wanted to be technical, you'd say this is atrial fibrillation with a ventricular rate of X. And that might be rapid, it might be normal, it might be slow. You know, we call it slow AFib or AFib with rapid ventricular response or rapid AFib. But atrial fibrillation doesn't quite meet the terms. The impulses are generated in the atria, but they're not organized. And so there's no real P waves, and the QRSs are usually narrow and irregular. So that's atrial fibrillation. In a similar way,
A-flutter.
a flutter, right? So this is a little more organized activity in the atrium, and it's atrial flutter. And calling it atrial flutter is also not quite enough because you want to describe what the ventricle is doing. And also in a flutter, it helps to describe what there's usually a degree of AV block. So what's the rate of a flutter? How fast does a flutter typically go? Let me ask the question better before you answer. The atria itself, how fast is the atrium fluttering?
It was like a 2 to 3 to 1 conduction.
Yeah, so you get slow conduction, but the atrium itself is usually fluttering about 300 times a minute.
Yeah.
Right? So if you were to count the distance between the peaks of the flutter waves, it's usually going to be about 300 beats a minute, which your heart can't do. And so you almost always will have AV block where if you're at 2 to 1 with a flutter, your ventricular rate will be at 150. If you're at 3 to 1, your ventricular rate will be about 100. But you'll get some degree of block. If you're at 4 to 1, it'll be about 75. So this is 4 to 1 with a ventricular rate about 75. So again, it's a flutter, but if you want to be perfectly accurate, you want to describe what the ventricle is doing and what the degree of block is. But again, this is the origination of the rhythm is from the atrium, and then you're describing what it's actually doing there. All right. And here's a flutter with varying degrees of block, right? This is fixed block above, where the block is the same, beat to beat. Below here, you have variable block. Sometimes the block is 5 to 1, sometimes it's 3 to 1, sometimes it's 4 to 1. And so you have variable block, and that certainly happens as well. So sometimes it's a flutter with fixed block, sometimes it's a flutter with variable block. All right. Questions on naming rhythms? All right, let's talk about conduction. I mentioned this briefly earlier. When conduction goes through the design pathways, it's fast. And when there's abnormal conduction, 2 things can happen. You can have a bypass track where it bypasses the normal conduction, and that's like a short circuit. It's also fast. Or you could have the conduction go through the heart muscle, and so that conduction becomes slow. So I'll say it again. When it goes down the wires, it's going to go fast. If you have a short circuit, that's another wire that's abnormal, that's also going to go fast. But as the conduction now spreads muscle cell to muscle cell, that's going to be slow. Fast things on an EKG are narrow, slow things on an EKG are wide. So here is a diagram of SVT, and we talked about this earlier, but in an SVT, you have an abnormal pathway here. It's an accessory pathway. It conducts quickly. It may conduct more quickly than the AV node. And what happens is the sinus node does its thing, goes to the AV node, everything travels down the pathways, but all of a sudden you get this short circuit and this cycles back up and comes back in here and hits the AV node again. And so it starts another beat without the SA node being involved. And you start a cycle where, that starts a beat, comes down here, up the bypass tract again, hits the AV node again. And it keeps triggering the AV node at a much faster rate than the sinus node would. And remember, we said the fastest rhythm in the heart is going to be the one that sets the pace. So this is how SVT happens. You have an accessory pathway that sets up a fast conduction that hits the AV node over and over and again, and it gives you what we would expect, right? You would expect then a narrow complex QRS, and you would expect no P waves because this doesn't have any chance to do anything because this is going so much faster. That's SVT. Does that make sense why that happens?
Mhm.
And that's why it's narrow. Now, if somebody had SVT, and let's say before they ever went into SVT, they had a bundle branch block and their QRS was wide. When they get SVT, they're going to have SVT with a wide QRS complex. It's going to look like VTAC. And you may not be able to tell the difference. And oftentimes, even in the hospital, we can't tell the difference. But assuming that the rest of the P waves and an narrow QRX with SVT. So let's talk about conduction blocks. So we talked about this extra pathway that goes fast. There are blocks that makes things go slow, and those blocks can happen in one of three places. Really anywhere along the conduction system, but three common places. And those blocks can be complete or partial. So sorry about that. So we have the AV node where we can get blocks, and we're familiar with AV block. We can have the right bundle branch where we can get a block, and we're familiar with right bundle branch block, left bundle branch block. So we're going to talk about these. These are things that slow down conduction through the heart. So let's spend a little time first talking about AV blocks because these are confusing and they all have multiple names, which makes it even more confusing. So we call them 3 degrees of block, but there's actually 4 different categories of AV block, right? 1st degree block, 2nd degree type 1, 2nd degree type 2, and 3rd degree block. These are blocks that happen at the AV node. We said that the AV node's job is to slow things down a little bit, put a little pause in there so that the atria can finish doing their thing before the ventricles contract. And that pause is usually of a certain length. If the AV node is working a little slower, then it'll put in a bigger pause. And so you will get a prolonged PR interval because the pause that it's putting in is longer than it should be. But every single P wave is conducted, and it's just that the pause between the atria and the ventricle is longer. All right. When we get into the 2nd degree blocks, we have a situation where not every single P is conducted. So if you have a P wave before every QRS and a QRS after every P wave, you have sinus rhythm. You could have 1st degree block, but that's the worst you have. All right. If you have a situation where some Ps are conducted and some Ps are not conducted, then you have a 2nd degree block. End of story. All right. And we'll subcategorize these in a second. But if you have some Ps are conducted and some Ps are not conducted, you have a 2nd degree block. If you have a situation where there's none of the Ps are conducted, then you have 3rd degree block. I know it's a little bit oversimplified, but it's not that oversimplified. This is the way I think about it, and I think it's helpful to think about it. If every P is conducted, it's 1st degree. If some Ps are and some Ps aren't, 2nd degree. If none of the Ps are conducted, it's 3rd degree. So we said the PR is fixed and prolonged in 1st degree block. It's the same length every time. It's longer than it should be, which is essentially the PR interval is greater than 1 big box on the EKG, greater than 200 milliseconds. That's your 1st degree block. In 2nd degree type 1, we have the PR changes. It's variable and it gets longer every time. So that's 2nd degree type 1 block. PR is variable and prolonging. In 2nd degree type 2, the PR is fixed. So you might think, well, 1st degree is also PR fixed. What's the difference? Well, here every single P wave is conducted. And in here, we said some of the P waves are not conducted. So you have some P waves not conducted, but of the ones that are conducted, the PR is the same. And with 3rd degree block, the PR is random. Some are long, some are short. There's no rhyme or reason. It's not getting longer and longer. It's just the PR intervals are random. So that's the relationship of the PRs and the three kinds of block. First degree doesn't really have any other names to it. We just call it first degree block. What are the other names for second degree block type 1?
Winky
Mobitz
Bach.
1 and Mobitz 2.
Bach.
or Winky Bach.
Yeah, so we can call it Wenky Bach, or we can call it Mobitz type 1. And what are the other names for second degree type 2?
Mobitz 2.
Mobitz
Mobitz 2, and sometimes you'll hear it called non-Wenky Bach. And what are the other names for third degree block?
AV dissociation.
AV dissociation, what's another name?
Complete
Complete.
heart block.
Complete heart block, right? So here's what we do. We take something that's already confusing to start with, and we break it into multiple categories, and I'm gonna give each category multiple names. I don't know why we've done this to ourselves, but this is what we have. Second degree type 1 is the same as Wenky Bach, is the same as Mobitz type 1. Second degree type 2 is the same as non-Wenky Bach, same as Mobitz type 2. Third degree block is the same as complete heart block or AV dissociation. So let's actually look at some of these. Before we do that, any questions on this? All right. So what do we have here?
First degree.
First degree block, right? The PR interval is long. It's more than one large box, but it's the same in every beat, and every single P wave is conducted to a QRS. This is first degree AV block. What do we have here?
Mobitz 1. Longer block.
Yeah, so this is probably a Mobitz 1, and here you might not be able to tell that the PR is getting longer, but when you get to this beat, you can see that this PR is longer than these, and then you have a dropped beat. There's the P wave that's not conducted, right? So, and then you start over again. So this is Mobitz type 1, right? Second degree block type 1. What's this one?
Mobitz 2.
So it's a little bit of a trick question.
It almost looks like a third.
Third degree.
Like a third
The
of
P
PR.
Yeah, it looks like a third.
We have more P's than QRSs, right? Everybody agree on that?
Yeah.
So there's a P wave, there's a P wave, there's a P wave, there's a P wave. We have more P's than QRSs. Are any of the P waves conducted?
That one,
Yeah.
that one.
Yes.
That one.
Yeah, so if you got P waves that are conducted, then it's not third.
Yes.
Because in third, none of the P waves are conducted.
Um,
All right,
Does this match?
so we're left with second degree block.
Oh.
It's one of the second degree blocks. Is it second degree type 1 or second degree type 2?
2.
Two.
So that's the right answer in this sense. Because we don't have two conducted beats in a row, we can't tell if the PR interval is getting longer or not. Right? If you had two conducted beats in a row, then you'd say, well, the PR interval is getting longer and then drop, or the PR interval is fixed and then drop. But we can't know. So that's this is what happens in 2-to-1 block with second degree heart block. You have 2-to-1 block. You can't tell if it's Mobitz type 1 or Mobitz type 2. So what do? You treat it like the worst one. Which is the worst one?
third.
No, of the second
Two.
degrees, which
How
is
about the
worse?
second degree?
Oh,
Two.
Two.
Mobitz 2 is worse. And so you treat this like it's Mobitz type 2. And you can't really call it one way or the other. That's why I said it's kind of a trick question, but you don't know. And so you assume it's the worst one and you treat it like it's Mobitz type 2.
Interference.
All right. And what do we have here? We have more P's than QRSs.
That's third.
Third degree block.
That's
Yes.
It's third degree block, right? We got more P's than QRSs. P, there's a P tucked in there. There's one here. There's one in there. There's one here. There's one right in the middle of QRS here, right? There's no connection between the P waves and the QRSs. None of the P waves seem to be conducted. This is third degree block. So there's a couple of ways to look at this. This is a way that I found, and if this helps you, great. If there's more P's than QRSs, then you know you're in a block. Is that PR interval fixed? If the answer is yes, then it's second degree type 2. If the answer is no, then then you go to the next question. Are the QRSs that look alike regular? If the QRSs are regular, then it's third degree. If the QRSs are irregular, it's second degree type 1. Let me show you another way that I do it. If there are more P's than QRSs, stand far away from the EKG and ask yourself, are their QRSs grouped or not? In other words, you have groups of QRSs and then pause gaps between them, or are the QRSs regular? If the QRSs are grouped, then it's one of the second degree blocks and you can narrow it down from there. And if the QRSs are not grouped, it's third degree. So let's go, I'm just going to go back to these. So here you have more P's than QRSs. And you can see that there's this group of QRSs, there's a gap, and then there's this group of QRSs. So this is going to be a second degree block, not a third degree. In this, you have more P's than QRSs, but guess what? The QRSs are regularly spaced. They're perfectly even. That's going to be third degree. So let's get through this again. What do we have here?
That's a third degree.
Third degree.
Third degree, right? There's more P's than QRSs, and the QRSs are perfectly regular. There's no grouping of QRSs. That's third degree. What about here?
Still third degree. I think.
Second
No.
degree type 1.
Second degree.
What?
Are there more P's than QRSs?
Yes.
Yes. Are the QRSs regular or irregular?
Regular.
Right.
Irregular. So this is another third degree. We're used to seeing third degree always being wide, but sometimes third degree, the QRS ends up being narrow. So there's a P wave here, there's a P wave tucked in the T wave, there's a P wave, there's a P wave, there's a P wave. There's no connection between the P waves and the QRSs here. This is another third degree.
So Joe, a third degree block, is it a ventricular rhythm then?
Not always, that's my point. Sometimes
Okay.
the junction takes over, or someplace below the junction, and it gets into the conduction system and conducts narrow. So it's not always a wide complex in third degree. You can have third degree with a narrow complex. That's why I put this in there.
Got it.
It's a good question. Everybody get this? Any questions on it? I think AV blocks are confusing to a lot of people. And so I'm happy to spend a little time on it if people have questions.
Okay, good.
Okay.
All right. So we talked about the conduction blocks at the AV node. Now we're going to talk about these guys. They can be complete or partial. Either the left bundle or the right bundle could not conduct well. Hang on a second here, sorry.
Call from 1 2 1 5 6 6 8 8 8.
All right, so normal conduction down. So if you have a left or a right bundle branch block, what happens is this. You get normal conduction down the bundle that's working normally, and that goes fast. And then you have slow diffusion from the muscle that's depolarized on the one side to the opposite side, and that happens slowly. So you get kind of the split in the conduction. Half of it's going down a healthy bundle branch, and that's going quickly, and then the other part is just diffusing slowly because that bundle branch is blocked. And so it ends up giving you a wide QRS complex. A lot of people come to me and they'll say, oh, I think this is a bundle branch block because I see bunny ears, but the QRS is narrow. And the first thing to call a bundle branch block you have to have is a wide QRS, and that's more than 3 little boxes. So the side that is going quickly will go quickly, obviously, and then the part of the QRS that widens and lengthens the QRS is the side that is blocked. So let me show you what that means. So V1, you know where you put V1, it's over on the right side of the heart. And V6 is over on the left side of the heart, right? So when the late rhythm is going to the right side, that means it's positive in V1. So the later part of the QRS, this is the beginning of the QRS, that's going fast. This is the ending of the QRS, that's going slow. When that's towards the right of the patient, then that's going to be a right bundle branch block. And when you look at it in V6, the beginning part's going fast, the end part is going slow. So V6 is over on the left side. That's why this is negative, because the right side of the heart, opposite of where the lead is the part that's depolarizing later. because that right bundle branch is blocked. So you'll always have a wide QRS. You may or may not get the classic bunny ears, but the end of the QRS will be positive in V1, which is on the right side, and negative in V6, which is on the left side. So here's a right bundle, right? You've got the rabbit ears in this one, but the ending part of the QRS is positive in V1 and V2, and it's negative in V6. It also usually is negative in 1 and AVL, which are your left facing leads. On the other hand, if you have a left bundle branch block, the right side is going to conduct quickly and the left side slowly. So in V1, which is on the right side, you get this little positive R wave, and then you'll get a big S wave. And that's the left side depolarizing on the rightward leads away from the heart. And in V6, it's going to be positive because that's, V6 will be positive because that is on the left side of the heart, and that's what's the depolarizing last. And so here is a left bundle branch block. It's usually negative in V1, positive in V6, positive in 1, positive in AVL. So again, you've got one bundle branch that's conducting quickly, the other one that's not conducting at all or conducting slowly. And so it's going to be a wide QRS. Left bundle branch block is going to be positive in the left leads. A right bundle branch block is going to be positive in V1 and V2 in the right leads. Make sense?
Mm-hmm.
So with any bundle branch block, when you have a wide QRS, what else becomes normal for that block? It's not normal, but what you expect is the wide QRS. You'll get some ST segment displacement, usually in the opposite direction of the QRS. And you will get a T wave that's the opposite of the QRS. So if your QRS goes down, your T wave goes up. If your QRS goes up, your T wave goes down. It's the same appearance of a PVC, where you get that bizarre complex that goes in one direction with the P wave, with the T wave in the opposite direction. So a wide QRS, some ST segment displacement, and the T wave in the opposite direction of the QRS. That's normal for the block. So I'm going to go back if I can here. So here in this right bundle that we looked at, right, QRS goes up, T wave goes down, QRS goes down here. That's actually the bigger part of the down, and this goes up and down. And if we go to the left, down and up, up and down. The T wave just opposite of the QRS. That's what you'd expect. The reason that becomes important is because if you ever see a bundle branch block where the QRS and the T wave are going in the same direction, that could be a sign of a heart attack. And we'll talk about that at the end if we have time. So it's a wide QRS, and the ST and the T wave go in the opposite direction of the QRS. All right. Let's talk about a patient who has a pacemaker. Now, we talked about the natural pacemaker that we all have. But here, if we have a person who has a pacemaker, it's placed on the venous side. They put it in the vein. They put the wires in. The wires go into which part of the heart, do you know? They go into the right ventricle. So the wired leads sit in the right ventricle. And so when they fire the right ventricle first, and then that spreads through the heart muscle to the left ventricle. The pacemakers do not use the normal conduction system of the heart in general, unless it's an atrial pacemaker. But most of these pacemakers sitting in the ventricle, and they don't use the normal conduction system. So that's why all patients with pacemakers generally have a wide complex QRS. And if it's sitting in the right ventricle and the right ventricle depolarizes first and then the left ventricle goes later, then it kind of looks like a left bundle branch block, because the right side's going first, the left side's going later, just like if you had a left bundle branch block. And so that's the reason why a pacemaker looks like a bundle branch block and looks like a left bundle branch block, not a right one. So if you have a pacemaker here, again, the wire's in the right ventricle, this is going to depolarize first, then the conduction is going to spread muscle to muscle cell to the left side, and that's going to be the end of your QRS is going to be leftward. So here's a pacemaker. You can see the pacer spikes, you see the QRS is wide. And again, you can see that the pattern of the pacemaker is just like a left bundle. It's positive in 1, positive in AVL, negative in V1 and V2. And the same thing applies with the T wave. The T wave is generally in the opposite direction of the QRS. And the ST segment usually changes a little bit as well. Everybody see that? Any questions on that? All right. Oh, this is just to break it up. Anybody know what this kid has? That's measles. We don't see much measles anymore, thankfully, but that's measles. All right. This little review here. What do we have here? Probably the bottom rhythm strip is the best one to look at. Do we have more P's and QRSs?
Third.
We have more P's and QRSs, right? Are the QRSs grouped or are they regular?
The Winky block.
They're grouped.
They're grouped. So it's got to be a second degree block. And yes, it's a Wenke block. So you have long, longer, longer drop, long, longer drop, long, longer drop. So this is Wenke block. That just blows up that bottom rhythm strip a little bit more. All right. How are we doing for time here, Mike? I can do some STEMI stuff, or we can call it there.
We have a half hour for you, Satch.
All right, let's do some STEMI. All right, so acute MI is a part of a spectrum of disease that we call the acute coronary syndromes. And we talk about acute MI in different anatomic parts of the heart. So when you look at a 12 lead EKG, at least the way that we set up our 12 leads here, we have six limb leads on the left. We have the chest leads or the precordial leads on the right of the paper. And they're arranged usually like this. And then we talk about which leads are looking at which part of the heart. So 2, 3 AVF look at which part? That's inferior wall. V1 and V2 we talk about as looking at the septum. V3 and V4 is
Anterior.
anterior wall. And then V5, V6, 1 and AVL are looking at the lateral wall. So AVR, we often ignore, although it probably shouldn't be ignored as much as we do, but we don't spend a lot of time looking at AVR in general. So we have inferior, septal, anterior, and lateral leads. And I think I just went ahead. I'm going to go in all this. I'm going to skip through most of these. So this is just the direction of that those leads look at from the heart. So V1 and AVL look from a more high angle on the heart, and then V5 and V6 look a little lower on the heart. So sometimes you get a little different view in those leads of the lateral part of the heart. And then V4 and V3 looking at the anterior wall. V1 and V2 look at the septum. What do we not generally look at with a 12 lead EKG? What part of the heart?
Posterior.
We don't look at posterior, correct? And what else, what other part of the heart? All of these designations are designations of the left ventricle. The inferior part of the left ventricle, the anterior part of the left ventricle, the septum, and the lateral part of the left ventricle. We generally don't look at the right ventricle unless we're doing right-sided leads. So again, we ignore AVR, and we tend to, with our standard 12 lead, not really look at the right ventricle. You can get some hints about the right ventricle, but usually we don't look at it. So when we talk about MIs, we usually talk about inferior, anterior, septal, or lateral. We'll look at a couple EKGs of posterior MIs as well. I'm not sure if I have a right ventricular infarct here or not. But that's what we're looking at. We're usually just talking about the left ventricle. So from a localization standpoint, that's what we're looking at. So we talk about STEMI. We say ST elevation myocardial infarction. And that brings up the point that we use these terms incorrectly all the time. Everybody does it. You're not doing the wrong thing, but it's probably worth understanding that what we call infarction is not really infarction. There are three words that start with I. The first is ischemia. That is lack of oxygen to the tissue. And that usually causes ST depression or T wave inversion on the EKG. So that's the first I, ischemia. There's injury. So when you have injury, that's prolonged ischemia, and that usually causes ST elevation. So what we generally call a STEMI, meaning myocardial infarction, is really myocardial injury. An infarct, that's the third I. An infarct is death of tissue. Now, what does an infarct cause on your 12 lead after the tissue is already dead? That causes a Q wave. And it may or may not show up, but when it does show up, that causes a Q wave. So when we say STEMI, we're talking about this injury, even though we end up calling it infarction. If we don't treat the injury, it will become an infarction, but it's really myocardial injury. So let's talk about this. You have normal heart muscle that's got good perfusion. You put a lead on the chest, and you're going to see the normal depolarization and repolarization of the heart. It's going to give you a normal EKG. Looks like this. If you have a little ischemia, this part of the heart on the inside, remember the vessels come from outside in. So the most ischemic part is going to be on the inside, or what we call subendocardial. When that gets ischemic, it's going to affect repolarization, and it's going to depress your ST segment, invert your T wave, or do a little bit of both. Okay, and that's why with ischemia we get ST segment depression, T wave inversion. We call those ischemic changes. That's ischemia. Inadequate oxygen to the tissue, subendocardial, ST depression or T wave inversion may or may not result in infarct depending on what we do. And so here's a good EKG of somebody with ischemia, right? They have ST segment depressions. You can see that laterally, anteriorly, inferiorly, everywhere. This person's in trouble. But there's, other than AVR, which again, we ignore for the most part, this patient has not infarction, but ischemia. They have ST segment depression. Here's another ischemic looking EKG. This person, you can see these ST depressions laterally, V5 and V6. They don't have ST elevation anywhere, but this is an ischemic EKG. When the ischemia starts to involve the entire thickness of the heart muscle wall, the entire thickness of the wall, then we call that injury. And that actually starts to cause ST segment elevation. So if it's just the subendocardial part, we get ischemia, we get ST segment depression and T wave inversion. If it's the full thickness, we get ST elevation. And that's what we call a STEMI, but understand that that's actually injury. So it's prolonged ischemia, it's transmural, the whole wall, ST elevation usually results in an infarction. And it's important to know that the first thing you see in injury is that the T waves get hyperacute. They get really tall. And when we say really tall, if you see a T wave that's just about as tall as the QRS, that's a hyperacute T wave. And that may be the first sign. Before the ST segment even rises, you see a hyperacute. I think this is an early EKG in their course, and you can maybe get the sense that these T waves are a little high compared to the QRSs. And then this is a little bit later on. And wow, these T waves are bigger than the QRSs. You could fit that whole T wave inside that whole QRS inside that T wave. Something's going on here. And maybe you're starting to get a hint that the ST segment's starting to rise inferiorly here. The other thing to note here is, what rhythm is this patient in? It's a junctional rhythm, right? There's no P waves, narrow QRS, 40 to 60 beats a minute, junctional rhythm. But these are hyperacute T waves. And then the ST segment starts to rise in the acute phase. And then you see that here. You see these inferior ST segment elevations. See how big these T waves are now? You can fit all these QRSs inside these T waves. And you've got inferior ST elevation.
Hey, Joe.
Yep.
With that hyperacute T wave, is there any way for me to differentiate hyperkalemia as opposed to the ischemia?
Not a great one, Ian. Sometimes we talk about the hyperkalemia ones as being a little more pointy, like a little sharper at the tip than the hyperacute T wave. But other than that, there isn't really a good way to separate the two. Mike, any tips on that?
I called a hyperacute hyperkalemia STEMI 3 days ago, so no, it's hard. You call it like you see it, and you could be wrong with hyperkalemia. It's not an uncommon or unexpected error.
I'm just trying to figure out what all those little squiggly lines are.
Dr. Usach has mastered the spelling of EMS and is now working on squiggly lines. So here's the progression. Right now you've got wicked ST elevation here, anterior, lateral, inferior. But the first sign in this patient was those hyperacute T waves. It just keeps getting worse for this guy.
That
So
almost looks like my MI.
yes, I'm sorry to hear that, but I'm glad you're still here to be in this class. So then what happens is after
back
these
in
ST
March.
segments are up, sorry. After these ST segments are up, you start to develop Q waves. And the Q wave is the sign of the infarction. And then the ST segment comes down, and then we call this age undetermined. You don't know when this MI happened, but there's a Q wave, there was an infarction there at some point, and everything's back to normal. So here's a patient with, what are we looking at here? Yeah, inferior ST elevations, but you can see the Q waves are already forming here in V3, right? So this patient's already starting to develop Q waves, and they've got some lateral ST elevations as well. So again, this is a pattern of injury, inferior leads. We'll talk about what do we call these changes in 1 and AVL in this EKG?
Reciprocal.
Reciprocal.
Reciprocal changes, right. So we'll talk about reciprocal changes and why those are formed here in a second. Infarction is the end of the deal. The damage has been done. The heart muscle's dead. We usually get a Q wave. Not every infarct gives you a Q wave depending on the size of it. And what a Q wave is this? You have this dead tissue. You have a lead here. This does nothing. And so when you look through this, it acts like a window. And what you're actually seeing is the opposite side of the heart depolarizing. And because that is going away from your electrode, it gives you a negative deflection of a Q wave. So the dead tissue just makes a window for you to look to the other side. So depending on how big the infarction is, depending on where your lead is, depending how much heart muscle you have on the opposite side, you may or may not see a Q wave, but that's what a Q wave is from. It's from this, this window, and you're looking through to the other side. This idea of looking through to the other side is the same thing that gives us reciprocal changes. So we'll talk about that in a second. So here's a patient with an old MI. He's had an old inferior wall MI, probably anterior wall MI. There's Q waves here. There's no deflection before. You don't know when it happened. The rest of it looks back to normal. So this is just a remote MI. Yes, so if you were to get, so this idea of looking, of one lead looking at this side of the heart and seeing through to the other side explains a couple of things. It explains the reciprocal changes. It also explains how we try to look for a posterior MI. So I'm going to skip this slide for a second. So reciprocal changes, when we look from here, we see ST elevation, and but if we look at that from the opposite side, that's going to look like ST depression and a T wave inversion, right? So we're just looking at the same thing from opposite sides. So when you have an inferior wall MI, well, your high lateral leads are going to look the opposite. They're going to look the opposite of what your STs and the inferior leads are doing. So you'll have ST depression and T wave inversion. We call that reciprocal changes. So for acute MIs, we want to know what to look for. We're looking for ST elevation, usually more than 1 millimeter in 2 contiguous leads. And we have this kind of seesaw where when 2, 3, and AVF are up, your reciprocal changes will be in 1 AVL and your V leads. When 1 AVL and your V leads are up, that's where your ST elevations are. Then your reciprocal changes will be in 2, 3, and AVF. So they're not necessary. You don't always get reciprocal changes with MI, but if you see reciprocal changes, they're very helpful. They're strongly confirming evidence when they're present. but they're not necessarily always there. In other words, if you think someone's having an MI, don't call it off just because you don't see reciprocal changes. If everything else looks like that, but when you do see reciprocal changes, it makes it a slam dunk. So here's your inferior MI, right? 2-3 AVF. And you can see that you have reciprocal changes in 1 and AVL. ST segment depression, T wave inversion. It's the opposite look to what you have in 2-3 AVF. On the flip side, if you have a lateral MI where you've got your ST elevation like V3, V4, V5, 1 and AVL are elevated, well, then 2-3 and AVF are depressed and inverted. It's just looking at the same event from the opposite side. Here again, inferior, 2-3 AVF are up, 1 and AVL are down. Now here you get a little clue that maybe something else is going on. V2 and V3 have these ST segment depression T wave inversions. That could be reciprocal changes as well, but sometimes that's the reciprocal change of what's directly behind V2 and V3, which is the posterior wall of the heart. So if you see a big R wave in V1, V2, and then ST segment depression and T wave inversion in V1 and V2, that could be the reciprocal change of a posterior MI. And so sometimes that's the only clue you have that someone's having a posterior wall MI, because again, that's not a part of the heart that we typically look at. If you want to go ahead and do posterior leads, V7, V8, V9, then you may see ST elevations there and be able to diagnose a posterior MI. So again, here, ST elevations, V1, V2, V3, you can see that 2-3 and AVF are a little bit depressed there. The ST segments are a little bit depressed. Reciprocal changes. And I think I just have a bunch of MIs in here. So V1, V2, V3, in the interest of time, I'll just skip through these. And here's again, lateral MI, anterior lateral MI, and you have the ST segment depressions in the inferior leads. So here is a big inferior MI. You got the reciprocal 1 and AVL. And this is also a posterior MI. V2 and V3, big R wave with T wave, ST segment depression, T wave inversion, V1, V2, V3. This is an infra-posterior MI. So let's talk for a second about things that could look like an MI that aren't an MI. And some of them we've mentioned already. So left ventricular hypertrophy. When the heart muscle gets really, really thick, well, the QRS gets the amplitude gets really high. The ST segment can be elevated or depressed depending, and it can make it look like an MI. We'll look at a couple examples of that. Bundle branch blocks, we already talked about. When you have a bundle branch block, QRS is wide, and then you get deflection of the ST segment and T wave gets inverted, but it can look like an MI. Any other ventricular beat, just like a bundle branch block, can look like an MI. You may see ST segment elevation there. Pericarditis is something to look for, especially these days, and it can mimic an MI because one of the signs of pericarditis on EKG is ST segment elevation. We talk about this thing called early repolarization, which is a very benign thing. It happens in healthy young people, but it can give you ST elevation, look like an MI. I think I have an example of that as well. And then there's a thing after someone's had an MI, if their ventricle forms an aneurysm, it'll give you ST elevation that looks like, for all the world, like they're having an MI. But we have the advantage in the hospital looking at an old EKG and saying, oh, they've had this every EKG they've had for the past 5 years. This is not an ST elevation MI. We wouldn't expect anyone to recognize that in the field, but just understand there's things that will look like an MI. You'll call a STEMI, and if we say, hey, in the end it wasn't a STEMI, it may be one of these things. So here's LVH. You can see that the voltage is wickedly high on this patient. If you look at V1, V2, V3, those ST segments are way up. And it would be very tempting to call this a STEMI, especially if the patient's having pain. But you get the sense that the ST segments are concave upward. They're sort of sloping upward. And then they're not symmetrical. The T waves are not symmetrical. They're asymmetrical. They're steeper on one side than the other. And this is the typical look of LVH. And notice the T wave inversions in the lateral leads. That's also typical of LVH, and those T wave inversions are also asymmetrical. It's sloping gentler on one side going down than on the side going up. So you look at enough LVH cases and you start to get a sense that this is probably LVH and not a STEMI. It can still be very, very hard to tell the difference. But this is one of the things that can mimic an MI. Here's left bundle. We looked at something like this earlier. And we said that left bundle branch block will give you a wide QRS, will give you ST segment depression, ST segment deflection in the opposite direction of the QRS. So this QRS is going down, this ST segment goes up, and the T wave goes up. When the QRS goes up, the ST segment goes down, and the T wave goes down. So again, it can be very hard to interpret MI in the setting of left bundle. We have some tools to help us do that, but this can mimic an MI. Here's another left bundle. Make you think, hey, well, are these ST segments up? And if a patient's having chest pain, it can be very hard to tell the difference. But on the other hand, here's somebody with a bundle branch block. Remember we said that normally the ST segment and the T wave should go in the opposite direction of the QRS. Well, look at V2. QRS goes up, ST segment is up, T wave is up. Look at V3. QRS is up, ST segment's up, T wave is up. This is a STEMI in the setting of a bundle branch block. And that can be one of the clues, is if it's not going opposite, if it's going in the same direction, then that's a sign of a STEMI. Everybody see that? How that's different than this? This, everything's opposite. QRS up, T wave down, QRS down, T wave up. Here you have QRS, ST segment, and T wave all up in these two leads. That's a STEMI. And this is a bundle branch block with a STEMI because, and we'll talk about this in a second, because the amount of ST elevation is very, very great. It's more than 5 millimeters here. So there's a set of criteria I'm not going to bore you with. We'll skip it. But you can sometimes see a STEMI in a bundle branch block. That's my point. But it's very difficult to identify. So I'm not going to talk about Scarbosa criteria. I'm going to skip that. I don't think that's of much value. But here again, you see, you get the sense that there's something going on with this ST segment and this T wave going in the same direction of the QRS, and that this isn't a normal bundle branch block. I'm going to skip this. Skip this. Here's a pacemaker, right? This patient has a pacemaker. You can see the pacer spikes. Same kind of deal. Very hard to see an MI with a pacemaker, but look at this lead. QRS is wide. ST segment and T wave all going in the same direction as the QRS. That's probably a STEMI. Here again, QRS is wide. It's upright. ST's upright. T wave is upright. That's a STEMI in the setting of a pacemaker. Pericarditis will cause ST segment elevation everywhere. So if you see somebody that's having chest pain, that you think they're having an MI, and they have ST elevation at every single lead, it could be an MI, but it's unlikely to get all vessels in the heart occluded at the same time. And so you think about whether it could be pericarditis. So this is an example of pericarditis. What else might you see with pericarditis on a 12-lead EKG? One of the other signs of pericarditis is PR segment depression, which again, not something we look for very often, except for in this case. But here, if you look at these PR segments, you see that they're downsloping and they're lower than the baseline. PR is depressed here, the PR is depressed here. This is pericarditis. Every single lead is upright. Every single lead has ST elevation and the PR segments are depressed. What you will never see in pericarditis is ST segment depression. So if you see ST segment depression, like a reciprocal change, it's not pericarditis. That's going to be ischemia or an MI. Here's another example of pericarditis. Look at these PR segments, especially in like lead 2 and lead 3 and AVF. See how low those PR segments are compared to the baseline? That's the PR segment depression that you get with pericarditis. This is benign early repull. We mentioned it briefly. It happens to be common in young men. And one of the clues here is that you get a little bit of a notching of the J point, like right here, we get this little notch at the end of the QRS that goes into this ST segment that's elevated. And these patients are usually there for something else. Somebody happens to get an EKG on them and the computer reads it as a STEMI and everyone freaks out, and it's just benign early repul. What do we have here? This is a sinus rhythm with biphasic T waves in V1 and V2, and some ST segment elevation. So I probably have this in here as a Wellens, which again, I'm not going to spend time on. Left ventricular aneurysm, this is what it looks like after an MI, where you have bulging out of the ventricular wall, and it will give you a big Q wave from the old MI and then ST segment elevation. So that is another mimic of an ST elevation MI. What time do we have here? I think I'm going to stop there, Mike, and just see if there's any questions anyone has.
I have a question, Joe. What do you think the utility of doing a posterior, if you see a STEMI doing a posterior EKG in the pre-hospital setting, you think it's reasonable to be, you see a STEMI, you're done, you see the anterior changes, and you think this patient could go hypotensive, need fluids? Do you ever see a role of doing a pre-hospital posterior EKG?
So I think if the diagnosis is clear, then I certainly wouldn't delay transport to do any other lead or fancy stuff. The goal is to get the patient to the cath lab as quick as possible. If you can do it while in transit and it doesn't slow anything down, then fine. But I wouldn't slow down the transport to get some fancy lead. If the diagnosis is in question and you're not sure whether I should go to a local hospital or a hospital with cath lab capability, and it really matters whether I'm going to diagnose a STEMI here or not, then there may be value. But I think that's going to be the exception, not the rule.
Joe, I popped in late. Did you show a posterior?
I did.
Okay, so I gotta tell you, I've never seen the utility of getting those leads in the field. First of all, we have the advantage of everybody casts around here, but if you're talking about the difference between Abington and Elkins Park, it's a different issue. But all the mainline health hospitals are going to be able to cath. There's just not a whole lot of benefit in, like you said, wasting the time. And people need to be very comfortable. All the literature shows that there's an accepted miss rate from the field of 20 to 25%. And that is accepted by the cardiologist. That's why we do field activations. So kind of just go for the gusto and call it if you're worried about it.
And then, Joe, why do you think you showed so many inferior infarcts and not as many anterior infarcts and other infarcts?
Because the inferior ones are just more common. I probably had more of those in my teaching file.
Because the ones with the other infarcts die in front of you. So whenever you see a nice anterior infarct, you see a lot of anterior changes, you see diffuse changes, be ready to move forward with defibrillation, intubation, and running a cardiac arrest. So always keep that in your back pocket. When you see something, always be ready for the inferior infarcts causing death. But if you see a big anterior one, it's coming pretty soon.
Did you talk about the arrhythmias associated with the infarcts?
We did not. And why don't you do that for us?
Yeah. So you know what? It's all anybody that was with me prior to Mike. You know, we call those the dark ages. Anybody was with me I always try to advocate for heads up ball. The smart money with the inferior infarcts is, what drug don't you give, Ian?
Nitro.
Oh, thank God. That you don't give the nitro. You get ready to pace because they're going to be much more prone to go into a complete heart block. And the flip to that is, if you're seeing an LAD or an anterior lateral lesion, I know there's a shortage of pads, but screw it. Waste the money, waste the dime, and put the pads on, because you've got a pretty high risk of going to V-fib or V-tac and have to defibrillate the patient. So just go for the gusto. You're not wrong. And your pads are interchangeable with the pads they use in the hospital. So again, that's just heads up ball.
Completely.
And the inferior ones are often the ones more likely to go into heart block. So you're not wasting the pads on them either.
Absolutely.
So just put the pads on. You might need to pace the one. You might need to shock the other. Have them ready.
Hey,
Ben, you just gave Pidgey a heart attack because we have all the new monitors and we're having trouble getting new pads in.
No, I know it's a national shortage. The good old days of using the pad to rip the hair off the body before you lay down, the one you actually defibrillate with, those are over. You don't have to torture patients the old fashioned way. Supply chain. That's what they'll tell you. They're all sitting off the coast of LA.
Yep.
Stupid West Coast.
Well, thanks, everybody. I appreciate your attention.
Thanks, Joe. That was great.
Guys look rock star good. Just saying.
We should probably take about a 3-minute break just to go to the bathroom.
I'm gonna put my slides up.
And then we'll go forward with Ben. Dr. Usach.
Mike, can you see the slides?
Again.
Yep.
Okay.